And I think we've got to realise that we're all learning on this path. Oops, that's the last talk. So I think we've covered quite a lot of the ground that Gerhard in the discussion that we had after Gerhard's talk. But hopefully this will be a little bit illuminating on the subject. So, okay, sorry. There we go. Okay, and at least you'll be able to see a few photos of what we're seeing in Tonga, if nothing else. So I think, as you've seen, there's very different paradigms to diagnosing scabies, and that's what we discovered in the first study that Gerhard mentioned. And that's important because depending on your prevalence, if you're looking for an association between scabies and rheumatic fever, the definition that you use is going to vastly change your prevalence and the association between the skin and RHD. And so there's two different paradigms really focusing on specific findings, ROs, delta wing signs, and there's also a focus on more sensitive findings, crops of papules associated with symptoms. And the IACS criteria, as Diana's mentioned, actually sort of don't, they kind of include both groups. So there's the specific findings are termed confirmed scabies, whereas the sensitive findings are termed clinical scabies or suspected scabies. I think the ideal is an objective test. I have to say I am an epidemiologist, not a dermatologist. Much of my experience has come from being trained by a Melbourne paediatrician who does a lot of work in the Pacific, particularly Fiji and the Solomon Islands, Dr. Dan Engelman. Many of the pictures are sourced from IACS archives, published study, and some of our field work. So I have to say, I started to question the textbook specific diagnosis of scabies, having had the disease many times, pretty certain it was scabies, seeing as it was associated with family members. We all got better after we treated almost immediately with permethrin or ivermectin. And I never saw a burrow, never saw a mite, and I desperately wanted to see that. Okay. So the symptoms are pretty straightforward. Itch is a big part of it. And many of the textbooks say itch in the family is almost pathognomonic, and we've been doing a little bit of work on our surveys, and if there's one question you're going to ask is there itch in the family? And that very strongly correlates with what we've been seeing in terms of the skin findings. Chronic, funnily enough, not everyone is itchy in our studies. In the Pacific, in the Tongan studies, we've done about three quarters of the children that we see who we think have scabies are itchy. It's often worse at night. It can be generalised or localised. So it can be all over, or it can be just in a certain limb or specific area. So I think this kind of summarises the debate that occurred after the last talk, is that there's these two different paradigms for diagnosing scabies. Burrows and mites, looking for burrows and mites. So here, this is from a B&J paper where you can see the burrow, the sort of translucent area, often easier to see in non-pigmented skin. We think it's associated with a high rate of false negatives, requires so it's specific but not sensitive, requires specialist skills and equipment. This is the approach that we've used on the advice of Dan, who's done a lot of work in the Pacific, looking for crops of papules on the extremities, which become either clinical or suspected scabies, which is sensitive, but as Diana said, it is less specific, so there's likely to be more false positives, but it's also more accessible. Okay, so this is the classic approach to diagnosing scabies, looking for the burrow. Burrow is usually sort of scaly, about half a centimetre in length. Sometimes with some magnification you can see evidence of eggs and the delta wing sign. It's often more difficult to see the delta wing sign, so I read in the literature in pigmented skin. So the Australian approach in the Pacific is to use this definition: papules in an equal distribution, which is papules on the arms and legs. And these are the areas of the body that are most affected. So most commonly the hands, also the feet, genital region as well. This is from the IACS criteria. Scabies tends to be a bit more generalised in infants. So what are papules? So these elevated, solid, palpable lumps, often they're easier to feel than they are to see. If they're more than a centimetre, they're instead called a nodule. So here's another typical example of what we see in Tonga. You can see papules in various states on the fingers and also in the web spaces. This is in the back of the neck. What is impetigo? So these reddish sores turning to honey-crusted crusts, coloured crusts. And we also, particularly in the Pacific, see a lot of bacterial infection, cellulitis, pustules, abscesses, cardinal signs of inflammation, along with collections of pus. So it's a messy situation what we see in the Pacific. We see, I think the Pacific's probably more straightforward than in New Zealand, because in New Zealand there's a lot of antibiotic use, a lot of steroid use, a lot of creams, a lot of lotions. In the Pacific there tends to be much less treatment, much less access to treatment. So we see this, the continuation from these papules to infection, to impetigo, to these crops of pustules and abscesses. This is a patient with, this last one actually had confirmed scabies from a skin scraping, and the patient had rheumatic fever. So this is a close-up of the papules that are classic. Scabies, often lesions on the wrist, are common. Feet and ankles, often common to see these lesions here as well. This is from an Australian document showing papules in the armpit, feet and ankles with You can see some evidence of hypopigmentation associated with the scabies, signs of infection. Here we've got the papules, pustules, and evidence of infection. These were reviewed by one of the dermatologists associated with our study, and she thought these were burrows, which are reasonably subtle, I think you'd agree. This is scabies in an infant, a more vesicular kind of form. So here's just a few more photos. Scabies and impetigo very strongly associated in the Pacific. In New Zealand, most of the literature just treats impetigo as a primarily bacterial disease. So scabies often is complicated, particularly in the Pacific, with bacterial infection, often crops of these little abscesses and infections. Here's an example of scabies and impetigo with you can see the papules along with the crusting and some infection. And in older adults usually crusted scabies can be an issue, so dermatologists talk about a velvety look of the skin. Often a scraping will show under the microscope will show evidence of scabies mites. Here's some more examples. This is scabies treated with steroid. Scabies incognito so this I think is particularly an issue in New Zealand, where many kids with itchy skin get plastered in steroid. And we had several cases in our prevalence study who were treated for eczema, came back with PCR positive scabies. So this is the IACS criteria. We've got confirmed scabies, where on the left you've got evidence from dermoscopy of direct visualization of the mite. This is what we are focusing on the advice of Dan, clinical scabies, suspected scabies, which is either typical lesions or atypical lesions and various history features. Here's some of the history features. So they're basically household contacts with itch or other lesions suggestive of scabies. So here's a summary, because the IACS criteria are, I think, unnecessarily complicated. So for clinical scabies, it's itch in an itchy family member and typical crops of papules in a typical distribution. For suspected scabies, itch and typical papules, or itch and an itchy family member and atypical papules. And there's often likely to be pus and crusts and infection involved as well. Yeah, I don't think the IACS criteria are perfect, but they're an attempt at trying to standardise the diagnoses. And our experience is that actually very subtle lesions that we've swabbed for scabies have actually come back positive after PCR. So here you can, for example, all you can see is a little papule, which is probably easier to feel than to see. Of course, there's differential diagnoses such as insect bites, eczema, as was mentioned, fungal infection, molluscum, chicken pox in febrile children. So we've kind of been training staff around simplified skin examinations developed by the Australians, which are summarised here. And this is how we record our data. So basically we're asking clinicians to examine the skin, tell us whether they're typical or atypical papules. Are there any other lesions, other diagnoses, anatomical site, itch and pain, which is really all we can ask about in Tonga because we don't have access to the parents or the family. So here's just some examples of what we see in Tonga. Typical scabies. This is what we'd call atypical, just one lesion rather than crops of lesions. You often see signs of infection. This is very common. Crops of papules here, the beginnings of infection. You can see crops of papules on a younger child. So just in summary, I think the diagnosis of scabies is fraught, and there's two major camps, the sensitive and the specific camp. Our experience and the advice that we've had from experts in the field is to go with the sensitive diagnostic criteria rather than the specific. In New Zealand it's often misdiagnosed, we believe, particularly considering the PCR evidence. It's often treated with calamine lotion, steroid. Classic symptoms are itch in the family. Classic signs, crops of inflammatory papules plus or minus crusting and infection. Burrows and mites are infrequently seen, and an objective test would be very useful. And Cello, our molecular biologist from Brisbane, has been very useful. So happy to take any questions.
Thank you.